do that. We get complacent. We just assume everybody knows who we are, but some of you might not have turned up to one of our events before. So I'm Amanda Allard. I'm Deputy Director at the Council for Disabled Children. And Anna?
Yeah, Anna Gardiner, Assistant Director for Health at CDC.
And Marie should probably, after that meeting with Lesley the other day, when Lesley said, I've never met Marie, Marie should probably make sure her camera's on and say hi.
Hi everyone, I'm Marie Hunt. I work as a Development Officer at CDC. I was just typing in the chat, but I can say here, we are recording today. So if you don't want to be recorded, please do keep your camera off.
Thanks, Marie, that's really helpful. And anyone else we need to introduce from the home team, Anna?
I think Adiba is maybe with us, and Lorraine possibly.
I've just seen Lorraine pop up. Do you want to say hi, Lorraine?
Hi everyone, I'm Lorraine Mulroney. I'm the National Specialist Advisor in NHS England Improvement. Good to see everyone. I'm looking forward to the next 2 hours.
Yeah, absolutely. So perhaps won't introduce them, but just so you know, we've also got Adiba and Andrew from CDC online, ready to jump in.
Sorry. Well, do you need to be in on that one then? Or? I'm going to speak to you, Sally, and just get a bit of a plan, and then I'm going to join the meeting because we're only doing introductions at the moment.
Thank you, whoever achieved that mutation. Just very wrong use of that word there. Okay, so we've introduced ourselves, and do we now have some polls, Anna?
We do, so I'll stop sharing my computer, my screen, so that Marie can bring the polls up. But polls to take I suppose the temperature around this theme first of all.
And just a reminder that that the instructions that were on a slide are now at the top of the screen that Marie's sharing.
And the link to the poll is also in the chat in very large font.
I was very proud of myself, Anna. I managed to put some slides in the chat this morning.
I still don't know how to do that.
I'll talk you through it. Oh. Okay, that's the fact that that is still what's the word I'm looking for? It's moving a lot. Probably means that quite a few people are still responding. Maybe it slowed down a bit. Should we move on to the next one, Anna, or give them a little bit longer?
Let's move on.
Okay.
There are a few.
Next question. So do the health providers have a quality assurance, which we've done in big words, process around the provision of EHC needs advice? That's relatively positive, isn't it?
I think so.
Okay, next question. Is there an agreed template in place for the provision of health advice? Marvellous. It is really useful to be able to get a sort of snapshot from so many different services, isn't it, Anna?
It is, and we did a similar exercise at our national event around workforce needs, and I would say there health advice was quite a strong theme that came up at that point too. So
okay,
helpful.
Next question, or is that?
No, there's still some.
I thought there were a few. So many opportunities for interaction. So on average across all health provision, timeliness in your area is? Well, at least we don't have any 0 to 25s, she said.
Move on now.
I was going to say, will there be a late flurry? And do health services have an opportunity to review the EHCP when it's been drafted? I know that was when I was still delivering the EHC and outcomes training, that was generally the biggest complaint, not seeing it. So it looks like things might have improved slightly, but that we still got a reasonably significant issue around that. Okay, next question. How well is health advice submitted as part of the EHC? Oh, sorry. So how well, I've phrased that badly. How well is the health advice submitted as part of the EHC needs assessment reflected in the final plan? And that presumably quite closely related to the previous question. Okay, next question. And on average, your service received timely notification of annual reviews? Question mark. It definitely does seem to be a difference in the level of formality with which people approach annual reviews and the processes that sit around them. And Matthew's made a comment in the chat. Yeah. And actually might be helpful to share the if we shared the legal in the list of resources that we share, and if we got that legal judgment around annual reviews in there.
The new one, no, we
Yeah.
don't actually. We'll share that with the email that goes out. That's a good point.
That's just to do with a judgment around the speed with which the plan is updated and the provision in place post the annual review. Next slide.
I think that's it for our questions.
Okay, super. Right, well, I think I'm handing over to you to do a lovely presentation on Anna.
You are, and I'm going to just share my slides again. So just a moment. And we are going to hear from two local areas, one very virtually by video, and one in virtual person. But first of all, we just thought it would be helpful to share some learning that CDC has learned from our delivery this year as we come to the end of our delivery year. So this is delivery under our Department for Education contract around SEND, but also from various bits of commissioned work we've done on EHC processes, our work with NHS England, the sort of intelligence that we get through our forums as well. And it is about the EHC process in the broadest sense, so not just specific to health advice within that, but critical that we kind of see it as a whole. So that's the point of sharing this, so kind of brief. We have done some focus work in Yorkshire and Humber in January, and it was specific to supporting health practitioners to write advice. And much like we did today, where we took a kind of sense check, a temperature check, we asked how they were feeling about writing advice. And as you can see there, for some of those people, we co-produced a session with DCOs across the region. So we designed something that was for those who aren't routinely asked to write advice or who may be new in post. So some nervousness around it. I think some people still finding that if they're not asked to do it often, it's often they have to get their head around the process as well as the actual activity of writing the advice. Some felt very comfortable, but a real kind of range of views about how people feel with that task. And I think it's important as well to set out what we at CDC think the ideal EHC process looks. Obviously, there is a set time scale and within that steps that have to happen at certain points. But I think it's really important to look at it as a whole, and that no element should be happening in isolation. And I'll give you a bit more context to some of these thoughts shortly. But essentially, that no element should be happening in isolation. So a child, young person, their family defines their aspirations at the start of that process. They're then supported to define some outcomes that will, in essence, lead to those aspirations being met or not, but outcomes that relate to their life and their wishes, and being supported to do that at the very start of the process, so that there are some outcomes that are sought that then can be shared with the practitioners around that child or young person, and to support them in writing their advice in an outcome focused way as well, so that professional, that practitioner, writes advice which is based on that child's need, beyond diagnosis, that they have sight of those draft outcome areas that the family, the child, young person wants, and that then they're able to write and recommend provision that will support the child and young people to achieve those outcomes in response to the need that they have. And then the plan writer in the local authority develops smart outcomes out of all of the ingredients that have come before. So the smart outcomes are defined at the end of that process based on the advice that has come from a range of professionals. And I think what we're seeing is that it's not happening in that way because there, certain steps along the process aren't happening to enable that. The other piece of work that CDC is about to publish, so coming to the end of March, there'll be lots of new resources coming out. One, we're calling our sort of EHC pinch points resource. So from the week 1 or pre-week 1 to week 20, the areas along that process that there are lots of challenges. So this isn't from any one local area or any one region. It's an amalgamation of all of our conversations, and you'll get the slides, so do look at that in more detail. I'll not go through this line by line, but I'll just highlight the barriers and the challenges that are kind of coming across. So we are seeing consistently that the person-centred conversation, where the aspirations and outcomes that are sought by the child or their family, where those should be established, it often takes place too late in the process. There's a bit of lack of clarity about who that conversation, who should be holding that conversation, and actually the comms around that conversation aren't always strong enough, so it's not clear what the purpose of it is for families, and then the professionals who then will get the information that comes out of that, it's not always clear how they use that. So we have made some recommendations about how some of those things can be addressed. They're not all things that can be addressed at a local level. Some of them might need some national training and national kind of steer on some of that, and we don't know what the SEND review is going to say. It might well be some of this that's picked up there, but we thought helpful just to lay out what we're hearing. On the next slide, so this is the point at which advice givers are asked to provide advice. So we're hearing, and I think through our poll, that actually they're not always, advice givers aren't receiving the individual's aspirations and outcomes when they're asked to provide that advice. Unsurprisingly, and the point of our conversation today, current statutory timescales aren't allowing that sufficient time, or certainly local area interpretations of that timescale don't allow for sufficient time to do that in a meaningful and robust way. So advice givers have insufficient time or capacity to respond to that request for advice in a way that is person-centred and high quality, particularly if they've not recently engaged with that child or young person, so if they've not had a recent interaction. Move the slide on. The advice givers that we hear, that we've spoken to, that we've done sessions with, feel they have insufficient capacity to coordinate and advice, coordinate and align their advice with other professionals' advice as well. Advice givers feel under pressure to recommend provision that isn't necessarily available locally, or that is available locally, but that might not be the best set of provision to meet that child's needs. So there's a tension there, and I guess that leads to parental lack of confidence and rise in tribunals, which is an issue in all local areas, and a kind of separate issue around tribunals for those who provide health advice and their role in that, and what that means for capacity, but also confidence and confidence and capacity. And then finally, the plan writers not receiving advice that's sufficiently specific enough for them to be able to turn the outcomes that have been discussed at the start of the process into those smart outcomes that we want to see in final plans. Similarly, not having sufficient specific information from advice givers to specify what provision looks like in a plan. We've just seen in our polls that practitioners are receiving insufficient warning of annual reviews, so they can't attend or even participate, by email, can't submit recent reports because they're not getting that notification in time. And practitioners having insufficient capacity to attend and meaningfully contribute to those annual reviews because of the not enough of a lead-in time, and then therefore those annual reviews being insufficiently person-centred. So some challenges that are probably going to come up in our conversations today. So I guess just to reassure you that we are hearing those things. We know that they're real issues, and hopefully some of the examples that we give you today will go some way to show how other areas are addressing them. But I think we don't have the answer in this webinar. I don't think any of us individually have the answer, but collectively I guess we start to look at how we address some of it, and with the SEND review coming out and new support contracts starting from April, I guess that can be a focus going forward. I'll hand over to Amanda just to, similarly to the slides before, but just kind of our key asks for change in this space.
I know. I was on mute. I'm trying to prevent you having to listen to the monsoon coming down on my conservatory roof. So based on that analysis, what needs to change? Shared understanding of challenges between agencies, so those pinch points. So I think that would be great when that's out. Training for those leading the person-centred conversations around aspirations and outcomes. Conversations about the children and young people's outcomes sought to routinely take place at the beginning of the process. We do have to take that seriously, and it can't be something that we suddenly realise hasn't happened. If we're going to deliver the cultural change that we need, as well as the outcomes for children and young people, and amended forms to effectively capture the voices of children and young people. I was always struck by one local area that we talked to where, they could really proudly stand up and say that they felt that they'd moved their EHC plans onto the place where actually they could really hear the child's voice. And that is so important and does make a real difference. So share aspiration and outcomes with the request for advice. Again, something that came up a lot in our EHC and outcomes training. People, basically providing advice in a vacuum. Next slide, please, Anna. And professionals to see each other's advice, and definitely in some of the case studies we're going to share with you this afternoon, that's happening really effectively. Simplification of paperwork so that there's minimal time commitment, and we've already had that come up in the chat, but a digitisation of the process, and that's something that is that in Lesley's presentation, or do we need to? She wanted us to highlight that to people, didn't she, Anna? That they use wasn't system 1, was it?
Rio, yeah. So it is
Rio.
her presentation. But the other, on that note, we have a resource coming out again at the end of March around EHC hubs and portals. So some case studies from areas that have gone down the digital route. So that will be something else we can share.
Health professionals to see the draft plan before it's finalised, and obviously that was something we looked at in the poll, because we know it's an issue, and training for the whole journey inclusive of tribunal work. And obviously, you know, in Lesley's presentation, you know, I think what's really clear is that, you know, is that actually part of avoiding a tribunal comes from, you know, good health advice, and, you know, and being really clear about you know, about where that advice has come from and why. An arrangement for some degree of MDT approach to define outcome and provisions for complex needs. There we go.
Thanks. And sticking with the sort of tribunal theme, which I'm sure will come up again as we go, there was a session last week that Mott MacDonald ran, which Judge Jane McConnell spoke at, and she talked a lot about, you know, advice within plans and kind of learning from tribunals. So I suppose just to reiterate, nothing that you won't have heard before, but I think just always helpful to hear it again. So the sort of specificity issue, so reports not being specific enough, I guess Jane McConnell just hammered home the sort of detail, but really being able to demonstrate the weight of evidence. So that's, you know, how many times that individual child or young person has been seen by a clinician, by a service over how many years. So demonstrating, really clearly demonstrating that that child and their specific needs are known. And what does a good report look like? It's about, you know, a really clear description of needs, clear description of the provision that's required as a result of those needs, and a description of the difference that we expect to see as a result of that provision being in place and those needs being met. So nothing that we haven't heard before, but I guess a helpful kind of reflection. And Jane McConnell also reflected that the role of the DCO at tribunal is really valuable. The DCO, the DMO in a local area, as a, you know, a supportive role in that process, and makes it a more efficient and effective process. So that's it kind of from our learning. Obviously there are lots of things to come out where you can unpick some of that content that we've just run through there in more detail. We do have a few of them are already on our website because they've been developed for a few years. So we have examples of good practice. When you get the slides, you'll be able to click on that link and it'll take you directly to them. We also have a specific resource around securing good quality health advice in EHC plans. That pinch points resource that I've given you a kind of preview of the content, that will be out soon too, as well as an FAQ document for those who write health advice. So that has come out of the Yorkshire and Humber training, but it'll be a resource that's available for everyone. We've also got a couple of resources around outcomes. So I suppose a kind of glossary: outcomes, outputs and impacts. So what's the difference? So we have a kind of professional resource and a parent resource. Just I think still lots of confusion about outcomes, so kind of an explainer. We've also got that legal briefing around the requirements to provide health advice in 6 weeks, so that's there at that link, and some e-learning that we developed last year, and I'll give you a bit more detail about that. There'll also be a hyperlink on the slides when you get them to take you directly to it. But a specific focus on health advice, so 3 levels. So level 1 for those health colleagues who are new to the world of SEND, so a kind of an introduction to SEND, the Children and Families Act, and you know, writing advice within the context of the EHC process. Level 2 for those colleagues who regularly give advice for EHCPs, and level 3, which is about supporting those colleagues who have a more strategic role, so focusing on kind of quality assurance, how the DCO is involved. Each level takes up to an hour to complete. Don't all need to be completed in one go. They're on our e-learning platform on the CDC website. You do have to log in or make a login to get to them, but there's no cost. They're free to access and free to use, and there's learning logs that you can capture your learning as you go. So do have a look at those and share with colleagues if that's helpful. There's also some e-learning on annual reviews on the same platform, so look at them all together. A helpful resource.
Super, thanks Anna. So if we could welcome Jo, who I have definitely seen, and marvellous. It's always a relief to know that your speakers are in fact with you. And we're going to be running your slides for you, Jo, so you get to say next slide, please.
Thank you. Okay.
So we will hand over to you, and thank you so much for offering to do this, Jo. Very much appreciated.
Thank you. Well, yeah, I'm here, a little bit nervous, but we'll crack on. So, yes, I'm Jo Pritchard. I work as one of the designated clinical officers in Devon CCG. So we cover Devon, Torbay and Plymouth. I've actually been enrolled nearly a year, so I'm quite new, and it started off as just a day a week, but that's recently increased, which is brilliant. Gives me more chance to do things like this. So yeah, I sort of put my hand up and said that we have an escalation process. I'm actually a physio by background, so I sort of bring a bit of an AHP to sort of stance to it as well, which has been really interesting, getting to know different people from different backgrounds. So it was just, yeah, so what I'd like to do, if we could do the next slide, that would be great. So what we sort of agreed that I'd do is just give a quick overview of EHC assessments sort of within Torbay. So we work as a virtual team across all the 3 areas, but I mainly am Torbay facing. So this one is about Torbay. It's a process that was already in place when I started. It had been sort of co-written and introduced to the area, but it was a piece of work that I was asked to sort of pick up and review again. So we're still running it, but what I'm going to sort of finish with is those sort of next steps, and we feel that it's still sort of in its journey to become hopefully a well embedded across all the areas. So if we just go to the next slide and just start with a bit of an introduction around Torbay. So we just pulled just a little bit of data around. So Torbay is quite a small unitary authority within Devon, even though there's quite a high percentage of children with special educational needs and those that then result in receiving an EHCP. So I sort of just looked at sort of just a snapshot over the last year, really. So from March 21 to February 22, there were 230 requests that were asking for health. So obviously that's not the total for statutory assessments. That's just the ones that were identified to need sort of health as part of it. What is interesting is we do find that we have a lot of children and young people where initially health aren't approached for input, and then as we go through that process and the needs are further discussed, we have multi-agency panels, and then we sort of identify that way that actually it would be extremely beneficial to have some health. But this is the ones that they go through that have identified. So there's 230 in total, and then if the next slide just sort of shows how out of those 180 are already known to those health services, and what the definition of that in Torbay is, whether they're currently open and being seen or if they've been sort of closed or discharged within the previous 12 months. We would expect that the most up-to-date report or some input from those health professionals. So obviously we can see we've got sort of 50 young people who would have requests from health but are either haven't been seen for longer than 12 months or maybe haven't even had the referrals are still in process, so they haven't actually been assessed yet. We have, with the waiting lists and things. That's fine to go to the next one, because that was what I was sort of going to move on to. Is then we did a sort of break it down, and we can sort of see that, we talk about those pinch points and things, and I think we already know in Torbay and Devon as a whole that one of our pinch points there particularly we can see is paediatrics, so getting to see that consultant. But I think what's really interesting for that, or just sort of a little aside, that there's a project going on in Torbay around looking at needs rather than diagnosis. So I think a lot of those sort of 97 sort of requests for paediatrics, a lot of that is around that need wanting for a diagnosis, when actually as we know, as we've just been talking about, it's really about that need and what the provision looks around the need rather than necessarily a label, and moving away from that. So yeah, it just sort of gives an idea of how that goes across the different health services. And what we see in Torbay is that those health services such as physio and the like the community children's nursing, those that have the quite fewer requests, it links in with our timeliness. So we often have very, very few late reports coming from those services that are actually able in a position to prioritise those requests within the 6-week time frame, whereas obviously with those people that, you know, those services that have got a high request, speech and language, particularly paediatrics, that also then have the long waiting lists. You know, we have those issues where unfortunately they're not able to respond within the statutory time, and we get the delays there. So what was put in place, if we go to the next slide, so the next few slides actually I've sort of lifted the protocol, the process that's currently in place, with the idea of being very, very clear of the escalation throughout the timescales. So like I say, this was a process that was jointly written and agreed between health providers, so between the Child and Family Health Devon and the SEN team, and also the sort of management level as well there to escalate up, and with the DCO and DMO sort of before I started. So we have a single point of contact. So that's the health single point of contact is notified when that request comes in. They also include in the email which health services that have already been identified that were being requested. That's then checked by them to sort of cross-reference those health services. If there's any additional services that are on the system, whether the young person, the child or young person is known, then they will be contacted as well. But generally it sort of starts with the requests that have come through. That then gets sent across for the request to go out, so out to those services. Most of those services, I would say, have the generic, you know, using generic inboxes. So physios, they'll go into the generic inbox, that will be checked regularly and then forwarded on to the relevant practitioner. So individually, within the health services, they have their own processes underneath this of how to respond and do it. One of the questions earlier, Anna, I was looking at was about the quality assurance and the checking of those. So I think I'm right in saying all of our health services within Torbay have an internal quality assurance and a sign off by senior manager. So the request will go through to the named therapist, professional, doctor that's there, but that will then go through there within those 6 weeks. Obviously, again, talking about those pinch points, it's that getting it out, isn't it? Getting the report back, getting it to the manager, and then getting it back to the SEN team. So they have internal ones there. So so hopefully that all happens and we stop at that level, because that's happened within the 6 weeks and the advice has come back, and that's all lovely. We're at the moment in Torbay around 50%. So yeah, we answered that question. We're around the sort of 50% mark. So unfortunately, 50% of the cases will exceed the 6 weeks. When that happens, so we have EHCP coordinators. They are amazing, and they have this spreadsheet, this live document that at any one point we know exactly where each child is at the stage, how long we've been waiting, who we're waiting for, what's come back in. So that is checked very regularly by the coordinators. So if the information isn't received, then the initial chase will go out. So another email again, just to that service that they're waiting for, saying, can we please remind you this? We're actually over the timescale. We now, we need to receive it. Could you please let us know when we might be getting it? I can see things popping up in the chat. Do you want me to grab them as we go?
I guess possibly the question about EHCP coordinators, are they CCG staff or are they local authority? And I can see Matthew's also put in quite a big question, which I think we might come to at the end.
I'm happy to do that at the end. Yes, we should have some time, shouldn't we? Yeah. So no, the EHCP coordinators sit within the local authority. So we have one. There's one within CFHD, so within health, and then they have a split role actually. So both of us, the one in Torbay definitely sort of works part-time as the HCP coordinator solely, and then part-time doing other admin for other sort of services, which is really, really helpful, because he just knows everybody and who everybody is and how to contact them, which is brilliant. So yes, they send the chases internally within health. If we get to a further 2 weeks, so we kind of get to the 8-week mark, and it's still not received, and there's been no sort of communication as to it's in process, and we're getting it. If we just sort of still unfortunately haven't had a response, then that is the initial escalation letter goes from the Assistant Director of Education to the Director of CFHD as the Children and Family Health Devon Health Services. So the letter sort of goes up to that sort of level, saying we're now being delayed. We need to know if we're going to be getting that response, and that's when it's also gets CC'd into ourselves. So we have our sort of generic inbox for the DMO DCO who we cover. We sort of have a rota that we cover it, so we can see them coming in. At this point, we don't normally actively try not to actively get involved, because obviously sometimes there's quite a few, but we will then just make a note of them to see, just so that we know there might be some issue, particularly if by then we will know which health service it is. And so sometimes we might know if there is particular sickness, we might know if there's a particular vacancy or something that we might be able to support with. And like I say, so there we've got those timescales, sort of that response within 3 working days. I think that initial, I know the discussion when we initially was put together was just to really try and, this is an escalation process, and we know at this point we are getting those quite delays for the family and for the young people, and they being able to draft the plan. So we've tried to keep those very short, those timescales, so that we can really move that forward. So then the next slide shows then that, so like we say, so actually if after those 3 working days we still haven't got a response, then that's when we would as a DCO try to make contact directly with those health service and offer that support. What's the issue? I mean, I was supporting one a few weeks ago, and it just generally was quite a new member of staff who actually unfortunately wasn't getting that support that they needed to help to complete it. So they were just feeling quite nervous about sort of pressing submit. So we just worked through that, supported them, linked in with their line manager, made sure, shared some of the training and thing that was available, and made sure that both the advice was being sent in, but also that person was getting the support they needed to be able to do future ones. Sometimes it's that it's gone to the wrong email address, or not the wrong one, but maybe it's gone to somebody who's on maternity leave and it's sat there and it hasn't forwarded on. It's just to try to unpick those bits and pieces, make sure that they've got that support to return it. So like I say, we will then link in with the coordinator and make sure that we're sort of trying to resolve that situation. And all the time we're copying this into health and the local authority, the SEND team, so that everyone has just got that transparency of what's going on, and that there is work going on behind the scenes to try to escalate that forward. The next sort of that the sort of internal escalations there with A and B, really what it is around if we're still unfortunately not receiving anything. Generally we find that is because of these 2 reasons, that, like we were saying before, that actually it can't be prioritised because of the capacity and the pressures within the teams. So that is, and the feedback from the SEND team is we'd rather know one way or the other. Actually, if we hear nothing, then you don't know what is going on, what the issue is. Actually, what we need is something from the head of services to say, actually, not even due to, but just this cannot be prioritised. This is this is the situation, and actually, unfortunately, that draft might have to go ahead without that advice within it. And also, or alternatively, that actually it's been decided that the advice isn't going to be provided, so it might be somebody that has been seen and there aren't any health needs, ongoing health needs, and actually they don't need to be included. There might be that they are actually on the waiting list and they won't be able to provide the advice until that has happened. And this is the sort of stage where we've sort of developed for, like we said, about numbers and reasons, to try and then actually look at that operationally, or try and encourage it to be looked at operationally, to work out how that can be unpicked a bit further to try and minimise that being the result. What is interesting here, and I'd be interested to hear if other people's sort of experiences, what I find with some of the health services, like we talked about, there's the sort of physio and some of those services that have got very few requests. Even if that child is on the waiting list, they will prioritise and see them within that time and do that assessment and give the advice. Whereas obviously other services have got very clear referral criteria and prioritisation matrices, and actually if that child is on the waiting list and may not be seen, maybe on a waiting list to be seen in a number of months, then they won't be prioritised for that assessment. So that's when those letters of sorry, we're not going to be providing it come through. So that's where we sort of are at the moment. And then I just sort of identified some of the next steps where what this sort of orange section is on the bottom of the process, but I don't feel that we haven't embedded that yet. So I feel that's one of my next steps now that I've got more capacity, is to actually be auditing and actually making sense of that data. So we've got it's there, and it's there, and it is being reported to through some of the governance structures. But I think it's at the moment it's a figure that's reported rather than something that we're actively able to do something about. So that's sort of on my work plan, is to really try to work together with the health teams and look at these, attend the sort of the quality assurance groups, and actually start to look at service wide how that can be used and improved, and then, like I say, so implement that regular reporting, so that we've recently had quite a lot going on in Devon, and restructure of governance and different statements of actions and things happening at the moment. So I'm really keen that this is quite central to those actions that are going to go forward to improve the health contributions to it. And then also looking at it wider. So like I said before, we've got Devon, Torbay and Plymouth that are quite sort of separate authorities, even though we as a DCO team work across all of them. So as we are working very closely together to look at this escalation process and make sure that it's replicated in the different areas, so that both we have health colleagues, the services that work across the borders are different for different services. So we have health colleagues that will work both in Torbay and Devon. So actually for them to have to work to two different processes it feels very unfair for them. So really trying to work with the teams to make sure that those the practitioners on the ground are able to follow the same processes, whether they're working in Torbay one day and Devon the next. So that's our sort of next steps and goals.
Thanks, Jo.
Sorry, I hope that wasn't. I know I talk quite fast sometimes.
No,
I forgot to tell you to tell me to slow down.
You are absolutely fine. And you do have some questions. Should we do the easy ones first?
Yeah, please.
Or maybe not easy.
And if I don't know them, I'll write them down and come back to you. But
okay.
Yes, I will.
So Laura wants to know, at what point would you give up and issue a draft without health advice?
Yeah, so I think we do. So I work really closely with the SEND team. I try and go to their EHCP panels each time. So what we find is if they're I will try and have that data before I can see the agenda. Like, for example, it's on a Thursday afternoon tomorrow, so there's a couple of draft plans that are coming through tomorrow that haven't got health advice that I feel really strongly we need it. So I've contacted them already and said, look, we're in draft, we're looking at it in panel. I need a time scale, because actually if they turn around and say it's going to be with you in a week or two, then my suggestion tomorrow at panel will be can we defer it for a couple of weeks and bring it back. Actually, if we are still at that point where either we've been told we're definitely not getting any, or we haven't got any timescales, then what we've done before is issued them, but very clearly stated that there may need to be a sooner review if that health advice, then when and if that health advice is then there. So we've got a young man waiting for speech and language therapy assessment. It's a huge part of his plan, but actually we decided that it wouldn't be fair on him to delay the rest of the provision. So he has got a plan and that's got a very clear note at, on the bottom bit about the annual review, that actually that we've took that bit out and we reworded it, saying that there will be an emergency review called as soon as speech and language therapy advice is available, to ensure that it's implemented.
Thanks, Jo, that's great. And does the single point of contact cover all parts of the health system? So comms, community, acute and CAMS?
Good question. Yes, so it will. Yes, I will double check that about CAMS. It definitely does for community and acute, yes, because I think it's sat within Charge of Family Health Devon, and CAMS comes under them. So yes, I think it is everybody.
Super. Excellent. And are there specific people, and if so, how many within the SPOC who do the chasing work?
There is one fabulous person for Torbay, and there is one fabulous person for Devon. So yes, and actually, that's interestingly, we had this issue which we've raised a couple of times around resilience within the team, and around that person having that absolutely fantastic knowledge and being 100% on it. Unfortunately, has been off poorly for the last couple of weeks, and there isn't that clear process in place about that. And we've got people that are supporting any urgent work coming in that needs to be covered, but actually that more routine, not routine, but that chasing work where that needs doing, it's not always covered. So yes, that is something that we've got a meeting about that next week with the wider team to see about how, from my point of view, it's we can't have a couple of weeks where we know that this process isn't being followed. So yes, it's at the moment one wonderful person, and we probably need a little bit more.
Might need a backup.
Absolutely.
So, and here's the most popular question, and in fact, probably the most popular question which CDC ever receives about health advice is, so what happens when a request comes in for a child that isn't known to paediatric services? So, do you see them in order to get the advice done within 6 weeks?
No. So no, we know that's a very, very clear within paediatrics. It's very clear that referral will be prioritised within clinical need, not EHCP. Doesn't result in jumping the queue, and that's one of the discussions, big discussions and meetings we're having a lot at the moment around. And like I sort of said, there are a couple of services that clearly do and feel that they should and they're able to, whereas we know that there are quite a few services that aren't able to, paediatric speech and language being two of them, just with the absolutely huge volume, and it's prioritised through clinical need, not that assessment. I'm really hoping that that's something that the review will be quite clear on.
Well, it would be good, wouldn't it? Because obviously that's not what the law says at the moment. So it'd be interesting to know be interesting to know whether or not that's something that you're thinking about sort of addressing within commissioning priorities. If the law should happen not to change.
Statutory requirement, isn't it? And have it, and the difference in what's the word? Difference in opinion of how things should be.
Now we have got a fair few more questions that have popped up in the chat, but how are we doing for time, Anna? Do you want to go to Lesley's video and then come back to those?
We're all right. We've got another 5 minutes or so.
Okay, so we've got a question about your DCO team. How many staff and what grades?
Okay, yeah, so there's so myself at 0.7, a full-time, and my colleague Bridget, who I think is on here as well, who is 3 days. So in total, I guess we're pretty much just over 2 whole-time equivalents, and at 8A, and we have 1 day of a DMO, consultant paediatrician, as well as part of our team.
Thanks, Jo. And Debbie wants to know, how is the process linked into the graduated approach, which might also support earlier identification?
Yes, so the process is all for the request for statutory assessments that have come through already. So I guess we're at the point where the statutory assessment it's been agreed that is needed. So in that sort of happening, so the graduated approach and the universal offer and things would have already been reviewed within the referral and the request. I don't know if that really answers the question.
So and I think Debbie's going to come back in and tell you.
Yeah,
go ahead, Debbie.
Sorry, it was just more around the fact that you've got a number that may well be unknown. It's just those unknown ones. how you can link into those unknown cases much earlier to identify them through that graduated response, so that they're picked up earlier before you get to that stage where you require that support. That's all I'm trying to.
Yeah, no, absolutely. Yeah, and I think with that, and I'm hoping that, so there's a new sort of pilot initiative that's being launched in Torbay in a couple of weeks called First Steps, and it's been a multi-agency approach between health approach, so paediatrics, physio, OT, speech, audiology, or sort of trying to bring everybody in, looking at those early identifications, looking at toolkits for parents to be able to implement very, very early on. It's very like we were talking about before, it's needs based. So it's absolutely, if a parent says, I think my child has a need, they're looking at this being an absolute sort of first steps. Okay, the first thing you can do is, here's a top 3 tips toolkit around all the early, those early sort of identification things, with the idea that they get to see a member of the team or the whole team, as depending on what's needed, to have those very early support conversations. So in theory, however many months or in advance, we should be reducing those numbers of unknowns, because hopefully a lot of those children, like you say, will be picked up a lot earlier, have that very early advice and support workshops and things, to then work out who needs to go ahead and have those more sort of detailed assessments.
And it may result in them not requiring an educational healthcare plan.
Absolutely.
So, yeah, brilliant.
Yeah, absolutely.
Thanks, Debbie. Jo, we've got a question from Julia about whether or not short-term care plans are included or referenced in the education, health and care plan.
Short-term care plans.
Do you want to
around
Julie, do you want, sorry, I've just, Julie, do you want to just come in and say a bit more? You're on mute, Julia.
Chatting away to myself, sorry. Yeah, I think we've kind of come across quite a significant challenge up in Bradford, where we provide, in some cases, some really detailed health reports, but they tend to be more of the sort of shorter term outcomes, whereas what our local authority colleagues are telling us, that the EHCPs, they want to really work across key stages. So key stage 1, key stage 2, and those outcomes are the longer term outcomes. So what we're really sort of struggling with is where we've got shorter sort of term outcomes within health, about how they are referenced as part of that plan. And we've had quite a few trips to tribunal, unfortunately, where we've not referenced health advice. Health reports have been submitted because we've done quite a deep dive into it. They just haven't been included by our local authority caseworkers, and where we've got some of our really complex children in special schools, where their health needs change almost on a daily basis. We have a whole special needs school nursing team that wraps around those and updates the care plans, and it's how we get that balance between those care plans being referenced as part of the broader EHCPs and the broader outcomes. And I don't know if you've got any tips or recommendations about how you're managing some of that.
I mean, so for what I've seen so far, so we have a standard pro forma that's filled out by health colleagues that is very much in line with the EHCP. So it's the identification of need, look at the outcomes, and then the provision. So I see a lot of, like you say, very sort of health related, the short, medium, and sort of long term, not linked to key stages, but linked to what that the child's needs and things are. I haven't had local authority coming back too much, sort of saying actually it needs to be in line with that. They're very supportive, I would say, in making sure that the health section is about the health of that child. We do, yeah, as you say, those very detailed day-to-day care plans around emergency, meds and changes of, support post seizures and things like that. Often they have then the individual health care plan separate. I think the health bit in the HCP is generally broader, rather than that the very detailed amount would be more held locally, like you say, managed by the nurses, managed by the school staff and things. So, but like I said, we have, I'm just thinking of one from a couple of weeks ago, some very, very clear OT goals, very, some very short-term ones, some very sort of quick fixes, if you like, and actually that, that I'd expect when the annual review came round that they'd very clearly not be followed, be on the next one, but then the more longer term ones as well. And the transition one, I think we haven't really touched actually, but I'm a big part of my role I really want to be developing is the transition, looking at the preparing for adulthood ones and the EHCPs. When we come to that, I think that's a whole nother debate around the length of time for outcomes and for goals, because as we know, a lot of young people are going to have some very long-term ones that we need to be thinking right through post 18.
Do come in, Anna.
Well, it was in relation to Juliet's comment in the chat. So could we discuss if we could agree that health outcomes are to avoid premature death, reduce comorbidities, attend learning opportunities? And I think there's lots of confusion about outcomes. That we shouldn't, in EHC plans, we shouldn't be having outcomes that align to any service. They should be holistic across children's life. And I think actually the 4 PFA domains are really helpful, a really helpful way to frame outcomes. And actually Juliet's outcomes in the chat, I think completely aligned to those PFA outcomes, but should be seen as whole system outcome, like whole outcomes for that child that the whole system responds to. I think there's just some terminology challenges, and I think the kind of health outcomes that Julia's just mentioned around managing needs after a seizure, that sort of thing. I think if we call that goals or objectives and they align to a service, I think that maybe helps us avoid the confusion around outcomes being seen as health, education and care within a plan. And in fact, when we listen to Lesley in a second, that's the approach they've taken in Islington, and I think she explains it and it seems to work quite well. You're on mute, Amanda.
Sorry. I was going to say, Anna, that I can see a question from Pippa around independent health advice, which I feel pretty sure is going to be covered off by Lesley's presentation. So should we move to Lesley now and then pick up questions that aren't answered by Lesley, and get Jo. Jo, are you able to stay with us?
Yeah, so far so good. Yeah, I've got a couple of people within the household that are having little 2 lines on their tester today, but no, so far everybody's hopefully happily just chilling out, so we're okay for now. If I do disappear, I'm afraid that would be the reason.
Well, fingers crossed. I just wanted to make sure that if we do leave some questions to the end that don't get answered by Lesley, that you might still be on hand to help answer them. So we of course will accept that sometimes COVID happens. So thank you very much for now, and we may well come back to you. Anna, are you pressing the button, or is somebody else pressing the button?
This is Marie now.
That's
hopefully
excellent.
Smoothly.
Okay, so over to Lesley Platts.
This one is being provided by Lesley from Islington, and she's going to be talking about integrated outcomes framework that she's developed in Islington. So I'll hand over to you, Lesley.
Hi there. You've got my slides, yeah. Thank you. Hi there, yeah, so I'm Lesley, I'm Head of Children's Services for Whittington Health, and I'm also the Designated Clinical Officer, and I'm involved in quite a lot of tribunals, as I'm sure many people are that are here. So I suppose the first question we need to ask ourselves is why do we need to prevent disputes in the first place? Bearing in mind all the things that have been said about relationships with families and how difficult that can be. However, there's also a cost to our tribunal system that we have at the moment, and I was really interested actually what Jane was saying earlier regarding how important it is that we're really clear and articulate about our provision that we're going to offer from the NHS, and that is the starter really of how we can prevent disputes, and one of the reasons why we have developed an outcomes framework. But I'm just very quickly just going to flick through some of the other reasons why we need to prevent disputes, so you can move the slides on. So one is that the increasing numbers of appeals that we have, which I'm sure all of you are seeing. We had a bit of a dip over COVID period, but we've certainly back on track now for having a number of appeals, and a lot of those appeals are about Section F, and I am a therapist by background, and that's an area where we are often drawn into the tribunal process. The next one. And we did a calculation about how many hours our therapists are spending either completing assessments or reports or attending a tribunal. And already we're up to about 126 hours of a clinician's time over a quarter has been spent on some of the work around the tribunals, and that doesn't actually include my time as the DCO, as a support officer for those clinicians, or the managers that also often get involved in reading reports and checking information before it goes to the tribunal. Next one. Yeah, and as everybody is seeing, this is just a really quick slide to say we're also seeing a big increase in need in our borough, and I'm sure that's the same for everybody else, which means often we're also then seeing a significant increase in requests for education, health and care plans, and the additional support that these young people will need either in mainstream schools or indeed in our special schools. Next slide. Yeah, and in Islington, we are doing some work with ISOS as well, looking at dispute resolutions and looking at one of the, the reasons are behind our increase in disputes in terms of our rates of appeals, the definition around SEN, and I think that's a really interesting one for us to discuss because the threshold for requests to assess has certainly changed in my time, and I've been around since statementing days. Also, the tension that there is between families and children and the local authority at times around some of the disputes that we're having can lead to a breakdown, and that's not good when we have children and families who we're going to be working a lifetime with. Next one. And this is just a very quick our win-lose rate, so we can see now we're not winning as many as we used to either, and that's not good for anybody either in terms of parental attitudes towards the local authority when they're perceived to have that we have perceived to have lost a case, and their trust in us can also be affected by that. Next one. And also, we can't forget the pressure that this can put onto our high needs funding. Often if we lose a case against, particularly if a private provider has put in, and I asked this question earlier, has put in a very detailed assessment of the child and with high level of recommendation of provision, and we lose that case and we're unable as a local authority or as a health service to provide the additional support that has been recommended or ordered by the court, then actually that often then puts pressure on our local authorities to fund either additional assessment or additional treatment packages, either from the NHS or from private providers as well. Next slide. Yeah, and this is just really just showing you again the number, and nowhere near as many as yours, Claire. As if you do say 1,000 a year, so yeah, we've got quite a lot of. I thought we had a lot of EHCs, but perhaps we don't have nowhere near as much as what they do for the whole of Somerset. But we certainly are seeing a significant increase in the request for education, health and care plans. Next slide. Okay, so the real crux of this presentation is really what are we going to do about making sure that families feel confident in the assessment and advice and interventions that we will provide in order to support their child's outcomes. So it's really important that we do provide very clear and measurable integrated goals that are specified and are very clear to the family about what is going to be provided and what the outcome will be. And this is really important because this information will inform about what appropriate provisions should be made, where appropriate placements should be made, and also measuring our effectiveness. So, how do we measure that we've actually met a child's outcomes within the context of the whole of the education, health and care plan. And also if we have any other challenges, if we try to cease the provision, then where is our evidence that we've actually met the objectives that we said that we were going to work on with that child and family, and also, the number of tribunals that we're having to attend. Next one. So we, a number of years ago actually, but probably implemented just pre-COVID, as many things were just about to be starting to go on, and then they went on a bit of a back burner, but certainly this is something that we've developed in Islington. And this is an outcomes framework, which is based on the outcomes from the Preparing for Adulthood. We've got 7 themed areas of goals within our outcomes framework. and there's detailed information for practitioners about how to write specific information on the education, health and care plan linked to outcomes that have already been specified. And also we have developed as part of that process an outcomes database, so that we're able to actually demonstrate whether we are working towards and meeting the outcomes which we stated in the education, health and care plan, and that they're linked to the 4 preparing for adulthood outcomes. Next slide. So what did we do? We had a number of away days with our CAMS practitioners, with our health team, education, social care, the voluntary sector, and our parents and carers from our Parent Carer Forum to agree details around what the outcomes should look like. And we developed what we call a bucket of outcomes, just to help practitioners guide them in their thinking when they're writing their education advice. And we also did a whole load of writing on SMART goals. Now, I feel like we've been talking about how to write a SMART goal for millions of years, but actually it was really good to go back and remind people what SMART really looks like. And certainly within our borough, the word ongoing is absolutely barred. And those of you who are in the audience from Islington will know that I constantly go on about anybody using anything that is ongoing is just not appropriate. Because actually, how do we know that we've met the outcome if we're going to be ongoing? We've also integrated this within our in our EPR system, so we are able to write adulthood system within our. We have Rio, and we can link that into Rio, and I'll show you that a bit more. This all helps with producing report and evidence around the effectiveness of the services which we provide. Next slide. We can move on from that. That's just reminding you. I'm sure everybody knows the PFA, but if you don't, there it is. So this is our bucket of outcomes that we have developed. So as you can see, it's all linked to the 4 preparing for adulthood outcomes. And within this, there are 7 different domains, which are all linked to a whole range of practitioners' normal advice. So the speech therapist might be writing, primarily around, developing friends and relationships. Mental health CAM services might be writing more around health and well-being. But this is a whole framework of different outcomes that you would be working towards. And as you see that they're all coded along the side, and the coding is linked to our Rio outcomes, so that we know which specific outcome that you've been working on in terms of your intervention with a child. So if you skip through these, because there's quite a few, so this is just showing you how they will go, and the final one is down to employment qualification. So you can see there's lots of different information that you could put into those areas. And we also give guidance to our practitioners on how we write medium and short-term goals within that, just to remind them this is how we want them to be writing those goals. Next one. Thank you, Robert. Yeah, that's the same thing as well. So each of those, we then have some examples for practitioners around how to write the goal. So once we did this piece of work, we've developed this framework, we've done a load of training for staff across the system in how to use it. We also developed a single, what we call an FA3 form, and I actually thought nationally it was called that, but I think it might be just an Islington name. So the FA3 is the advice form that is requested from education before we issue an education, health and care plan, and the information goes into the plan itself. So this form is collated on a central database, and it's completed by all the practitioners in the NHS who are working with that family, so therapy, paediatrics, CAMS, nursing, etc. And they're all asked to contribute on this single form so that it prevents duplication. So we're not repeating the same things as some of the other practitioners have already said, and that we then make sure that the information that we are writing around outcomes and our goals are then put into our database. All the submissions on the FA3 are checked by myself as a DCO, and there's a lead key worker for all of those applications that are put forward, so they're double checked with them to make sure all the practitioners have contributed before it goes off. This is all then recorded in one place, which means that we know who's late in providing their information, which gives me as a DCO leverage to go and talk to those clinicians to make sure that they get their information in within the 6 weeks. And we can look at what the hold-ups might be and any issues that we might have in providing that advice. And we can share this across the borough as well. So we share this practice and we work across 4 boroughs in Islington, Haringey, Barnet and Camden. Next slide. So this is what the form looks like. And again, it's got basic information about the child. We always ask about the child's voice, if that's possible to get that, and obviously about what the parental aspirations are. Next slide. So you can see there the template with the areas of skill deficit and development areas and how this impacts, the most importantly, how does this impact on this child's ability to be able to access education and the different areas of the PFA. And then these are all summarised, and then on our final sheet we look at the PFA areas and what are the outcomes that we are looking to work towards. And of course, the focus often, unfortunately, is around what resources might be required in order to meet that needs. Next slide. You can move on from that. That's just in case you don't know how to write a SMART goal. I will come back to something else on that in a minute, but I just wanted to show you, if anybody's on Rio, how easy it is to record an outcome linked to the PFA within the patient specified functional scale, the PSFS. Which is in Rio already. So we use that by putting the code that we're using on the framework so that we know when we come back and measured it, we can record whether that goal has been met, partially met or not met at all. So that's, if you're in a Rio system, that's where it is in the Rio. You can move on to the next system. Yeah, so then this links into our whole database. So that information is pulled through into our what we have ClickView, which is where we get our clinical information from, which comes directly from Rio. Next one. And yeah, and so this then pulls off a report through that outcomes database, which is, this is where it was right at the beginning. But if you move to the next slide, we're now up to, yeah, so you can see there we've got over about 2,000 goals that we have measured as to whether we have achieved them or not. And the report that comes off is generated will show you which area of the PFA that we have worked on. And on the next slide, it will show you how much of those goals have been met in terms of the level of improvement that has been made in each of those goals. So obviously 89% here, there's been significant improvement, and that will be linked back to the goal that has been established already. Also, we're able to pull off here details about how long it takes us to complete the assessments and what our percentage of completion is within the 6-week time scale as well. So all this information really just gives us evidence about the effectiveness of the local service, and I think that's really important in instilling confidence with parents and people. Next slide. Okay, so I've just given you an example here of something that we use quite a lot now in tribunals, particularly, but also in writing all our advice, is that we must be very specified. And Jane mentioned that this morning. And these are kind of some what you must do. And I'm just going to give you an example on the next slide here. Yeah. You move to the next slide. Yeah, so here, you must never leave in any doubt. This is what I always say to the practitioners, never leave any in doubt. What are you going to deliver, how you're going to deliver it, and what you hope to have achieved by the end of that. So this is just a very simple example of something that is really specified in terms of this young person will receive a 35-minute session per term in reception with a suitably qualified speech therapist to support the development of speech language and communication skills. Each session will consist of 20 direct minutes of actual doing therapy, 15 minutes of indirect contact, so that could be talking to the TA, and a 30-minute session per term to monitor staff's ability to be able to carry out and update advice and strategies within the classroom. And then we take it even further, just so that nobody is really in any doubt what we're going to do. We then specify what it is we're going to do in terms of a direct session. So this will, in this example here, it will include developing PECs, etc., etc. If you move to the next one. And then we also, as important, which often is forgot, is what indirect sessions will also look like. So this is what we're going to provide in terms of our indirect sessions for that additional 15 minutes and the other 30 minutes that we might provide per term as well. So I think you can see how clearly specified that is. And our feedback from tribunals is that they've really welcomed this, because it just leaves you in no doubt what you're going to get. Whether there's a dispute still, whether that's enough to meet the outcome, clearly that's something we would be in tribunal about. But anyway, I think it just gives it a really clear understanding of what it is we're going to do. Next slide. Yeah, and they're just some, you must look at your terminology, make sure you don't have too many outcomes, and use an MDT approach, I think is really important. And using a framework like PFA is really helpful in terms of articulating a single language of outcomes across your borough. Next, or area. So I was also asked to just mention about what we do in terms of writing for a tribunal. And I suppose we have a standard template which we've developed over a number of years to make sure that our evidence and advice is weighted as strongly as the 32-page private provider advice that we often are in tribunal up against. So I've just given you, I can give you the whole template, but I've just pulled off a few things that I think are really helpful. One is about your professional declaration, and to give really good details that you are a professional in your own right, and that you've got a number of skills and number of years of experience of working with children. And it's really good to remember to put all your training that you have also been on, because, you know, I'm an OT by background, and the amount of times we're asked for a, you know, suitably qualified sensory integration therapist rather than an occupational therapist is quite frustrating. Next slide. Yeah, so just to expand on that, we often put in what our experience is. So, you know, I've worked for 25 years as an occupational therapist, working with children with autism, blah, 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 blah. To just give a brief that you are a credible witness, that you've got a degree, you know, and any other specialist training that you might have. And also, really importantly, how long have you known that child for? And this is something, again, that Jane mentioned. That's really important because, you know, you're more likely to have known that child for a number of years and seen the rate of change that child is able to make with intervention. Next slide. Yes, and then this is about where you put your specified information here, and the goals and the treatment approach that you're going to use as well. I think that's a useful thing because, you know, even whole classroom treatment approach, you know, is an approach to working with children, and that needs to be emphasised, that language and communication is embedded within the classroom, and that you would be working to expand that for the whole classroom, not just this individual child, is really important to put in. As well as, you know, any group or one-to-one treatment that you may or may not do. And then also you could put in here about whether the child has plateaued or whether they've progressed despite having intervention. So you might have given this child a significant amount of intervention previously, and actually they didn't make very much progress. So actually that approach of direct work hasn't worked or does not work in this context. So again, you can put all those kind of pieces of information in here, and also a programme of what the work is that you would be expecting the school to do. And that's something you often don't see from the private provider, but it's something that certainly the NHS nearly always provide a kind of programme for the TA to put in as well. And I've just re-emphasised here to try and demonstrate that we know the child very well, and it's based on our experience with the child that is why we make this recommendation. Next slide. And then the other slide, which I think is probably quite unique to us, and I'm not sure whether anybody else does, I'd be interested to hear, is that we also put in evidence-based practice in here. So we may even reference journal articles. We will certainly be referencing, for example, the Royal College briefings on sensory integration. They would all be referenced in this, you know, our different approaches like co-op, etc. Our take on things like handwriting, where's the evidence around occupational therapy being the lead for developing a child's handwriting, etc. So that's a really, and also, you know, evidence around how good a whole school approach is, or a whole classroom approach to supporting a child. So we would put in our evidence and references there at the end as well, which I think is really helpful. Next slide. And then this is really, and this is my point also this morning, is about never be afraid to appraise the private providers advice, even though it can feel quite daunting, particularly if you don't know the child. And this sometimes happens, you know, that the child hasn't even been referred for speech therapy or OT, yet we're getting a private practice report saying this child requires, you know, weekly, daily therapy. So, you know, we have started this much more recently, and Robert, who's on the chat, will probably also be able to say something about this. And I think it's time consuming to do, but actually it could have a good outcome, and we're waiting to see whether it does. But this is really around, don't be afraid to dispute what the private provider has assessed or recommended. You need to reflect on your own current caseload, that you're already working with children who may have a similar level of need. Present an integrated approach, because it's not just about a single provider. You know, the approach that you get by working with your local provider is that they're already integrated and embedded within a whole MDT or multi-agency approach to supporting that family. Challenge clinic-based first versus classroom-based activities. You know, we're constantly saying we shouldn't be taking children out of school for an hour session in a clinic room if they need, you know, sensory integration, which sometimes has been recommended. That's a detriment to that child's education, and also is that child's ability to be able to transfer that skill back into the classroom. And also, is it something that educates and trains the child? So again, you can challenge on that. Again, use your evidence-based interventions and your research and knowledge around different approaches to that child. And shout about your own CPD, saying, yeah, I haven't seen this child, but I have worked with lots of children over many years who have got similar levels of need, and I'm embedded within the working style or approach within your local area. And again, you make sure you use college guidance as well. I think that might be it. Yeah. So that's a whisper.
Right, well, obviously we don't have Lesley with us, so you can't ask her questions, although I'm sure if there is anything that you would like us to follow up with Lesley, we can try and do that. But yes, she's not here, other than through the wonders of modern technology. If we've got some discussion time in the breakout groups anyway, Anna, so should we do you want to explain the Jamboards?
Yeah, so we have some prompts on Jamboards to get discussion going in the breakout groups, but I don't think we'll need to do too much to spark discussion. So I think start off with just reflections on what you've heard. It's a chance to have some more kind of focused discussions. But from the last session, we took your feedback that you wanted just to be able to digest what you'd heard in smaller groups. So start there, and then the Jamboards, we will capture any comment, any reflections on the topics there. You will, so that's about the barriers to the provision of timely advice. Thank you, Marie. Enablers around timeliness, and back to, I think Matt initially raised that, but the point around a request being made for advice and someone's not known to a service or is on a waiting list. So, you know, if you're doing something that is, you know, some practice around any of those themes, let us know and we'll capture it. You should have someone in your breakout group who can be a scribe, but Jamboard is very simple. If not, it's like a virtual flip chart and post it. So that little sticky note there, type, save and move it around the board, and it saves automatically, so don't worry about saving. So yeah, we'll go into groups, have some discussion, and then we will come back to the main group just for the last 10 minutes or so to take some reflections, and we'll tell you what our next steps are in terms of sharing.
Thanks, Anna. And just to confirm, I've got somebody to help me because you know I won't be able to manage the Jamboard.
Yes. and if the Jamboard, if all goes wrong with the Jamboard, type in the chat.
Okay, I can do that.
Yeah.
I'm just opening the breakout rooms. They should open soon, hopefully.
Thanks.